Hello, this is Dr. Karthic Natarajan from the Synapse Pain and Spine Clinic in Besant Nagar, Chennai. I am an interventional spine and pain physician. Today, we are going to be talking about shoulder pain or a common condition called frozen shoulder. Now, this is something that we see very routinely in our practice where we have patients who have frozen shoulder. Now, what is frozen shoulder? Now what happens is the shoulder joint, if you see, is a ball and socket. So you have the socket and the ball is moving, so the shoulder is moving. So this is a beautiful joint where we have maximum mobility in terms of rotation of our arms. Now the socket and ball are covered by a structure which is a covering called capsule. Now once in a while, this capsule tends to become sticky. So this is more common in patients with diabetes. So patients with type 2 diabetes are known to have sticky capsules. So this capsule will get stuck to the joint in patients with diabetes. Now this is a condition which we call as adhesive capsulitis. Adhesive meaning sticky, and there is inflammation of the capsule. Now, adhesive capsulitis can occur in normal people as well, but it is more common in patients with diabetes. So, in this group of patients, these group patients may be already taking treatment for diabetes and they may have their blood sugar under reasonable control, but in spite of it, they may have shoulder pain. This can occur on the right side or both sides. So, this can occur on either side of the body. So, typically, this group of patients will have pain on lifting the shoulder. They may have pain when they lie down on the respective side. They may have trouble in combing. They may have trouble in wearing their undergarments, that sort of thing. Now, typically, along with control of sugar, the doctor assesses how much is the range of movement, which we call as abduction. So, usually, we call it as 0, 90 and 180 depending on how much the patient is able to move. And whenever you have a situation where the range of movement, which is abduction, is restricted, we consider this as adhesive capsulitis. So we confirm the diagnosis. So we may ask you to get an X-ray or a scan to confirm the diagnosis, and the diagnosis of adhesive capsulitis is made. The severe form of adhesive capsulitis, where patients are not at all able to move their shoulders, that is called frozen shoulder. So in adhesive capsulitis, first thing we ask is, we ask you to control your blood sugars in meeting the diabetologist and taking the appropriate anti-diabetic medication, which may include tablets or insulin. After the sugar is controlled, what we do is, initially we may advise you to apply ice fomentation on the affected shoulder. Along with that, we may give anti-inflammatory medication for a short duration, maybe 5 days to 7 days. Once the pain and the inflammation is better, with medication, good sugar control and icing, we ask the patients to learn shoulder mobilization exercises from the physiotherapist. So the physiotherapist may teach the patient shoulder mobilization exercises. This includes exercises like the pendulum exercise, the wall climbing exercise, and good range of movement exercises. So typically, conservative treatment for adhesive capsulitis of the shoulder includes good diabetic control, regular walking, medication which includes anti-inflammatory medication, ice fomentation, and shoulder mobilization exercises. Now sometimes this adhesive capsulitis can take some period of time, so the patients have to keep doing the exercises regularly. So usually what we encourage this group of patients is, obviously this is more common in the 50, 60, 70 age group patients. So what we encourage these patients is to have a walk in the morning, which could be anything from 30 minutes to 45 minutes. A bit of sunlight would be a good idea, considering there may also be some vitamin D deficiency. After you finish your walk, you come back home and do the shoulder mobilization exercises for, let's say, 15 to 20 minutes in the morning and 15 to 20 minutes in the evening. Along with this, as soon as you get up and before you go to bed, you can ice the shoulder joint. And patients with adhesive capsulitis, till it is healed, it is better not to lift anything heavy weights, buckets, gardening, water cans, better to avoid lifting any heavy weights. So with conservative treatment, we find that majority of patients come around with adhesive capsulitis. Now there is a group of patients in which with medication, with icing, with shoulder mobilization also, they are not able to come around. In this group of patients, there are two types of treatments that we offer for adhesive capsulitis. The basic treatment is a intra-articular shoulder injection. Now, intra-articular shoulder injection is something that your pain physician may offer you. What we do is we confirm the diagnosis and under ultrasound guidance, so we keep the ultrasound probe in your shoulder, give good local anesthesia, and then we inject some medicine into the shoulder joint. The intention is to free the shoulder joint of the adhesions that are formed with the capsule. This is a very basic procedure. After we do the shoulder intra-articular injection, we can consider doing the shoulder mobilization exercises again. Now, studies have shown that when shoulder injections are done blind without under ultrasound guidance, the accuracy is compromised. So it is better to do the shoulder injections under image guidance, which is ultrasound guidance. Now, there are a group of patients who have very severe adhesive capsulitis. So in severe adhesive capsulitis, in this group of patients, they are not even able to lift the shoulder up to 60 degrees or 90 degrees. So if your shoulder abduction is restricted to 60 or not less than 90 degrees, then we may do another procedure which is called shoulder manipulation. So shoulder manipulation is done under general anesthesia. It's a very short procedure. So we give what is called short general anesthesia. So this procedure may last for about 5 minutes, but in order to keep the patients comfortable, we give general anesthesia. And then after we give anesthesia, the doctor will mobilize the shoulder to full range of movement. And in doing so, we may break the adhesions that are formed with the capsule. So we do the shoulder mobilization under GA. And after we do the shoulder mobilization, we do the ultrasound guided shoulder intra-articular injection, which is a joint injection. So in patients with refractory, that is difficult to treat adhesive capsulitis, the solution is to do a shoulder manipulation under GA followed by a shoulder intra-articular injections. And we find that some of the really bad patients where people have already tried other treatments who have not come around have become better and have got their full range of movement with shoulder manipulation followed by intra-articular injection. So this is a very safe procedure. Along with this, you need to continue doing the shoulder mobilization exercises at home and also to control your sugar as best as possible. So conservative treatment is icing, anti-inflammatory medication and exercises. If you don't come around with this, we have an option of going for shoulder manipulation and shoulder intra-articular injection. I hope this video was helpful. Thank you.